Very good evening to one and all. Welcome back to the today's session. So today we have our guest speaker, Dr. Arun sir. So we welcome you, sir. We welcome you, participants. So over to you, Ashika.
Hello.
Ashika, over to you.
Hello.
Yes, yes, you are audible. Over to you. Yeah.
Yes, ma'am. Good evening to everyone present, and welcome to Homeovision webinar series organized by All India Homeopathic Student and Youth Association. So today's guest speaker is Dr. Arun Gawande, sir. So let me introduce him. He is MD in Homeopathic Materia Medica from Palghar. He has done his PGDMS from Symbiosis, Pune. He is homeopathic consultant at Dr. Gawande Homeopathic Clinic in Sambhaji Nagar since 2008. He is ex-consultant at MGM Super Specialty Hospital in Homeopathy in GIT Specialty Department. He is visiting consultant at Unity Homeopathy Multi-Speciality Center is in Sambhaji Nagar since 2023. He is associate professor at Department of Pathology at Shri Bhagwan Homeopathic Medical College, Sambhaji Nagar. So today's topic is role of homeopathy in pathological cases. Over to you, sir.
Uh, Thanks, ma'am. Uh, may I start now? Hello.
Yes, sir. Please continue, sir. Over to you, sir.
Okay. So, first of all, thanks to this association, that is All India Homeopathic Student and Youth Association, for inviting me for this webinar. And the topic is today's topic is homeopathy in pathological or surgical cases. Uh, so, can you see the all first slide is visible to all?
Sir, actually, there is no screen sharing only, sir.
Yes.
Okay, sir.
Now you can see.
Yes, sir.
Okay.
Continue, sir. Yes, sir.
Uh, Going to next slide. This slide is moving to next slide.
No, sir.
Now
Yes, sir. Now it is moving, sir.
font size is okay.
Objective slide is there, sir.
Okay. Now, okay. So today is our topic: role of homeopathy in pathological and surgical cases. Right. So we will come to the first slide. That is objective of the this session. Most important, first we have to understand what is the pathological cases and surgical cases, right? So according to pathology, whenever there is a change in the at the level of organ, tissue or cell or microscopic level, that is a change, and that is an abnormal change. We can study that in books of the pathology and surgical surgery. So we have to understand uh, why I am taking this lecture first of all. So what in next 1 hour we are going to study the connection between pathology, surgery, and medicine. This we have to learn. Next, whenever uh, a surgical case or pathological case come to a homeopath, most of the time we see the complicated cases coming to our clinic rather than simple cases. So most important, how to accept that case. Is there any chance of life threatening situation? We have to, is it curable? Huh? Then we can accept that case. When we are confident to the case, then we can accept that case. Fourth objective, understanding the process of erecting the totality. And fifth part is the pathology, dose repetition. That we are going to learn in the case. So next slide. Can you see the next slide? Learning journey. Hello. Hello.
Show learning journey.
Okay. So learning journey means how it is started. I am sharing my experience. First of all, you can see this is the 3 year I have spent in a as a PG student. I am working in MLD MHI Palghar Hospital as a PG student, where I learn in the concept of IPD homeopathy, that is indoor patient homeopathy. And in that indoor patient, I have experienced many cases of surgery, orthopedic, even casualty, and that learn in the form of a chain system. That means a consultant, a medical officer, team of three to four PG student. It is a teamwork. And after that, passing out my PG, I started my early practice in 2010 time. That time, early days, I have to take advice or guidance from my senior teachers. And after that, I become an independent practitioner now. So it is a slow process. It is a gradual process to handle such a complicated cases. First, we have to learn as a student. Then we have to start early practice. But still, we have to connect with our teacher for the help, and then we become independent. It's like a little bird, a small bird which hacked the egg and come out of the egg and then started flying gradually. So next part, this is the first case for me when I was student, PG student, about to finish my PG. I have seen this case in the IPD department of Malad Hospital of MLD MHI, and this is a case of post amputation state. You can see the picture of post amputation with the great toe. This is the right leg of the patient, 82 years old patient with the case of gangrene, diabetic foot. And there was a case came to a surgeon. He amputated the case, great toe, and after that case came to homeopathy. And this was the change after the amputation. In the first side, you can see this is the case photo of on the day of amputation, and this is after some time. And you can see the black color and the slough. That is a starting of again gangrene process in that foot. So that case came to homeopathy, and we took a opinion to an orthopedic surgeon. He said there is a need of second surgery, advice for below knee amputation in the view of increased sugar level and condition of the wound. there is a black color and slough formation, there is a chance of again process of gangrene will start, and then there is a need of second surgery, that is a below knee surgery, that is amputation suggested. Patient and relative are not ready for this. So we took a case. You can see in the picture, this is my name as a primary physician. These are two observers, Dr. Rahul and Dr. Natasha, and supervisor, my teacher, Dr. Bipin Jain sir. So it is a teamwork, and in a teamwork we gave prescription to that case. We started with the carbo animalis, and that time the totality is taken, and the first remedy came as a carbo animalis. And after that we took a detailed case. After result with the carbo animalis, we gave MacCarb. And this is the picture of step-by-step photographs taken from my mobile at that time. I preserve that material so that everyone can see this, the change. And this is the case of a surgery, repeat surgery advice, patient relative not ready for this, and we started with the homeopathy. So this is the scope, our scope. When patients relative are not ready, when there is a risk of life in danger, old age, diabetic patient, and second surgery immediate, and the gangrenous process. So this is the change you can see after first, second page before treatment, and third picture is the after carbon analysis. And this is the last follow-up you can see. I have few more pictures in between, but I took few representative pictures. So this was a learning process for me. I was student, but this case gave me a positivity and confidence about how homeopathy works. When there is a limitation of the situation, when there is a patient not ready for surgery, and when we have a chance to take this challenge. So I was a just student, witnessed the process of cure or palliation. It was all teamwork, team discussion, surgeon opinion. We also took surgeon opinion in between the process of this palliation, and it is an integrated system. There is also role of diabetologist to manage the diabetes part, and it is a support and guidance of the teacher. That time I was just a learning under my teacher, okay, how the case is managed. So this was just experience in a PG student. Should I move to next case? Hello. Hello.
Yes, sir.
Should I start to case?
Please continue, sir.
Okay. The speed is okay for all, or a little bit faster?
Sir, screen is visible, sir.
Okay. My speed is okay.
Hanji, sir.
Okay. So this is the real start of the presentation. That was the last just experience. So I will start the case number 1 in my own clinic, and it is a clinic case of initial first year of my begin practice as a beginner homeopath. So this is the case. You can see this baby is not actually patient. This is a just representative picture taken from internet. So important of case is this is the post-surgical sequelae of walk syndrome. What is walk syndrome? This is the congenital anomaly. So this is the case detail. 2010. This was the time the case came. 27/7/2010. Age 1 year 4 months. A female baby, and she is on liquid diet, only liquid diet. Solid not allowed by the surgeon, pediatric surgeon. And father 30 years old, company worker. Mother 29 years old, graduate, left job during pregnancy. This was the situation. The data we collect in the format of LSMC format. Just I will minimize the font that you can see the whole data. So this is the data. The location you can see. This is a GIT, small intestine, at the age of 6 months. When baby was 6 months, this is the past history. She had a episode of vomiting, loose motion, bleeding PR, per rectal bleeding, bright red color. That time allopathic medicine was given and she was better. Again after 3 months, the similar episode came. But that time the picture is different. The red color jelly likes to. So this is not characteristic. This is the diagnostic criteria of the disease by the surgeon, pediatric surgeon. So it was the picture of intussusception with congenital intestinal malrotation with right ectopic kidney. This was the Walk syndrome data in this case. That time when she was 9 months old, the surgery done, surgical correction surgery was done, and after that she was asymptomatic after that surgery with appetite increase. That time appetite increase as a concomitant. Generally what happen whenever we see intestinal serious illness, there is a decrease in the appetite. That is a common symptom of the disease. But in this case, there is a appetite increase during this intussusception. So next, this is the third row. This is the patient came to me, and that time there is a vomiting of ingesta. Whatever she eat, that come out. That is a milk. Whenever milk given to her, that coming out in the form of vomitus. Appetite decrease here. That is a common symptom. Stool hard, straining, painful, and USG done. In USG, the picture came as a subacute intestinal obstruction. This is the state. And at this time, patient came to me, but first of all they went to surgeon who had operated this case in the past, and the surgeon said, we will observe this, we will admit this, and we will start the IV fluid and IV medication. If the patient is better with the medication, IV medication and IV fluid, we will give the discharge. But if the condition is worse, getting worsen, then we have to reoperate if there is a situation come. And this is the panic situation of the parents. Already at the age of 9 months, that baby is operated, and now her age is 1 year 4 months. Means it is just 7 months after that small baby, and doctor is talking about there is a chance of need of surgery if the condition is worse. And this is the concomitant you can see, and this is the modality. So this is the about Walk syndrome in general. What I saw in the books and on the internet, that is it is a Walk syndrome means it is intussusception and intestinal malrotation. When malrotation happen, when baby in the uterus, in intrauterine life, that malrotation, that is a congenital anomaly. And we can see in the picture, you can see all the abnormal changes and position, change in the position of that intestinal organ. For example, the cecum goes to left side, the transverse colon goes to right side. That malrotation changes goes in the abdomen during the development, intrauterine life. And there is a few variation of Walk syndrome different. In this case, there is a intussusception with malrotation. So this is our data got. This is the X-ray of that baby. You can see the water fluid level. That is a diagnostic criteria for intestinal obstruction. X-ray standing shows multiple air fluid level. That is a diagnostic criteria for intestinal obstruction. Advice admission, yes, second surgery if needed. And there is a high risk in the second surgery. That was the word of that parents, they told me. And the issue came to acceptance or not non-acceptance. Everyone can write down in the chat box. This is the situation. You want to accept this or not accept this. You can give your the opinion. What is the thought came to your mind? Will you accept this case in your OPD as a physician, or we will refer to another homeopath or another surgeon? So this is the situation in my mind. The referring person was my friend. He is the general practitioner, and he sent to me with a confidence that Dr. Arun will manage this case. You go to him. So I took this case with the help of my teacher, who is from Pune city, and I constantly connected with him. So this is the first case in my practice. The previous experience was a teamwork in a hospital as a student, and this is the case as my physician. But I took support of my teacher on phone through email. So it is a journey process you all can do in your practice. When you are a beginner, you took support of your teacher. When you are expert, you can manage individually the case. So pediatric case, first point, underweight. She was very low weight baby. Already first surgery done 9 months before. It is a high risk second surgery. So parents are not ready, and major is the financial issue is going on. In previous slide, there was written that mother left the job. Left the job. She was the teacher. She left the job because of pregnancy. So this is the case. This is my observation brought by her parents. Fear, curly hair, short hair. She was very cranky. This is the situation when close to her or trying to touch her. She is a cranky and irritable, and is silent when carried by the parents or taking outside the cabin. So this was the situation. Next, this was the detail about the parents I took. Mother, middle class family. She came from middle class family. She was a graduate, well studied personality. Mother doing private job, but there was a disfigurement due to burn in her early childhood. When she was in school, that time there was a case of burn to mother, and so her parents were ready to do marriage with a poor guy, less educated guy. And father from poor family background, less educated man, 10th pass, and working in a company in less salary. So this is the difference, and the cause of this difference is disfigurement due to a burn. So this is the a short image of all data, all live space. I have all consolidate it one image. Just I will explain one by one. This is a mother. Mother was confused. The situation about the pregnancy. This is the about pregnancy. Mother unplanned after 2 months of marriage. Means I have started my inquiry from the pregnancy. How was this is the case of congenital anomaly and operated at the age of 9 months. So when this is started in the womb, in the uterus of the mother. So I took back to the detail of during pregnancy. What happened during pregnancy? So it is unplanned. Why unplanned? You can see in the next slide the difference. There is a one difference, and this is a financial. There is a this is a financial issue. There was a financial issue. So there was a unplanned pregnancy after 2 months of marriage, and there was a situation come as a no traveling, and that time mother was confused whether to continue this pregnancy or not continue. There was a conflict situation of a mother. If she continue the pregnancy, then she will land up into more financial problem, because she have to leave that job, and more financial problem is coming. And if she will not continue, she will abort this child. Then there was an experience. You can see the elder sister had infertility after 2 abortions. So she had a fear that if I will abort this child, I will land up into infertility. So she continued this pregnancy. And father, you can see this is a happy father, because he is going to a father. So he was happy. And the situation is, one is the health issue, so no traveling, and the in-laws asking her to come to Diwali in her village, in her husband's village. This is the mother means. So there is a conflict situation again. First conflict situation is the continuation of the pregnancy. Second is the doctor said no traveling, and in-laws said you have to come to a village for Diwali. So there is a confusion. There is a risk of abortion, doctor said. Gynecologist suggested there was a bicornuate uterus. So doctor said take a rest. And there was a what emotion generated? The anxiety, fear, abortion, sadness, all emotion are generated, insecurity. And what the somatization effect of that anxiety? That is a hyperemesis, PIH, pregnancy induced hypertension, and IUGR, intrauterine growth retardation. So I inquire further, how is the relation between husband and wife, the parents of that child. So there is a, at the end of pregnancy and after the birth of patient, there was a frequent quarrel. You can see the frequent quarrel between both, and you can see the give less time. Husband was give less time to the wife, less care of wife, because she is not listening to his parents, not going to village on Diwali. So there was a frequent quarrel. This is the data taken about the patient, playful, active child before the disease. During acute, she became irritable, cranky, aberration by carrying, taking outside the cabin, that was the observation. Obstinate, moody, intellectual development corresponding to age was good. There was no retardation of mind or memory. Fear of stranger, hide behind the mother. If any stranger talks, touches her, cries. Fear of loud noise and scare cry. This is a physical general of the case. This is a USG report. You can see there was a subacute bowel obstruction. This was the report, first report, sonography report. And this is a weight 7.5 kg, abdominal distension, tenderness, and this is the abdominal girth. This is very important in the case of obstruction. You have to take daily abdominal girth. So we have to go in a depth of this case. After collecting all data, I called to my teacher, and there was a discussion between sir and myself about this case, what we can do. So initially I thought I will start with some acute remedy as per the totality, and then I will think of a chronic constitutional remedy. So remedy generally thought of plumbum med, chamomilla, and opium. These were my thought process. But the suggestion came from my teacher. The most important suggestion. He said, my teacher said, this is a recurrent tendency of system. This is the third episode. And this is the need of, there is a constitutional remedy in this case. Acute will not work to manage such a case. This is not acute. And there was a two group came in a repatriation and in a mathematical differentiation, Calcarea and Baraita. And after differentiation of two remedy, I come to the conclusion that this is a close similar to a Calcarea, and she was the hot patient. So two options come in my mind, that is a Calcarea oil and Calcarea sulf. So this is the totality that I made and sent to my teacher. You can read all. Fear of stranger, fear of noise. This is a mental, obstinate, hiding behind mother, temper tantrum, head banging to floor, pamper child. Physical, this is a lean, fair, cranky, round face, curly hair, perspiration profuse, hunger, aggravation, craving sweet, and all these hot patient. And this is the repetition done that time. The remedy come. First remedy was Calcarea, and this is the at 7 to 8 position, that was a Baraita. That was the two remedy taken from repetition. And this is the difference about Calcarea. So the main difference in Calcarea Baraita, there is a in Baraita there is a problem at the level of development of a brain, and this baby is there is no mental signs of mental retarded child or MR child or cerebral palsy. There is no problem at the mind, and in Calcarea there is a location. You can see the Calcarea location in the glands, GIT, absorption, assimilation. So location was the GIT intestine. This was the difference I made that time. And these are two calcarea, hot calcarea, and other all calcarea are the chili. So this is the difference between calcarea iode and calcarea sulfate. And then we took a detailed difference of these two remedy, and you can see the involvement of intestine in calcarea iode, the problem at the level of digestion, assimilation. She was underweight and more obstinate child, that is a calcarea iode, tubercular syphilitic miasm, increased appetite with marasmus. This is the picture of calcarea iode. And one more reference taken from Dr. N.M. Chaudhary, Matra Medica, about the calcarea. There was a line written in Matra Medica, puts right many of deviation occurring during pregnancy. This was the sentence which is very striking, and puts right many the deviation. Deviation means the congenital anomaly, that power of remedy calcarea, and also useful in disorder related to secretion of milk and childbirth. This was the data I got from Matra Medica, and I saw the power of that calcarea medicine in the managing a case of congenital anomaly. And this is the calcarea 200 single dose given, 3 doses given. These are the date: 27 July, 28 July, and 4 August. These are the repetition. Tuberculin 1M single dose given on 7th August. This was the last prescription, tuberculin 1M dose. And after that, placebo is given, kept on SL. So this is the reason for why tubercular myasm, sudden onset, intussusception, loss of appetite, failure to thrive, recurrent episode. This is a follow-up criteria. These are the data. Generally, we keep record. We learn from Palghar days how to take follow, and you have to meticulously arrange all on paper or in your Excel sheet, so you can study the case, action of the remedy, and take a further action. This is the all dates, or this is the, you can see all column as per this follow criteria. This is the record, sonography record. This is the first sonography, post-operative status. Post-operative status of malrotation, low pace right kidney, mildly dilated bowel loop, and ectopic malrotation rotated. And this is the follow-up. As you seen the X-ray and previous sonography, there was the fluid level, air fluid level, multiple, and this is the no fluid level, no signs of obstruction at present. You can see the date 6 October 2010, and this is the 17th July. And this is the letter given by the mother to me. This is the thanks letter in Marathi about her experience. She was thankful to me and my friend Dr. Manoj Madi, who is the general practitioner, who referred this case to me. You can all read This, the essence of the letter is the just she want to share her experience and she was very happy. And त्याच्यामध्ये लिहिलेलं आहे की आतड्याचा त्रास माझ्या मुलीला झाला नाही यानंतर, म्हणजे 10 वर्षात. द लेटर रिटर्न आफ्टर 10 years in 2020. Case taken in 2010 and the letter written 2020 after 10 years. And she said in this 10 years there is no GIT complaint to my daughter. This is the feedback from the patient's mother. So should I move to next case? Hello.
Yes, sir.
हाँ.
Yes, sir. The session is till 8:30, sir. Yes, sir.
Okay. So we will take little fast next cases. This is the case of gangrene of fifth toe of left foot. This is the picture you can see. This is the fifth toe, the little toe. And this is the case of gangrene. Suggested small amputation. There was a fear, anxiety. And patient came to me from a village. This is the data, location, sensation, modality, action. You can see how the data is collected, and most important is the bluish blackish color, the pain, burning pain, anxiety, health about, fear of amputation, weakness. And patient on antihypertensive, Telma 20. This is the physical data taken, all physical characteristic taken. And patient is a brother of a BHMS doctor. In first case, referred by a BHMS general practitioner, and this is the brother of a BHMS doctor, who is also general practitioner. This is a family history. You can see heart disease problem are predominant in the family, and this is the life history. This is the final totality. This is the personality data. Calm, quiet personality, less talkative, fight, fear, different fear. You can see. And how this patient came to me. He was from 150 kilometers away from a village and first consulted to local village doctor. That village doctor referred to this case to a surgeon, and the surgeon said, we need amputation, small procedure, and we have to remove that gangrene part from that little toe. And it is a minor procedure, not a major. But there is a, he said, a surgery and amputation. There is a give rise to fear and anxiety. So that surgeon referred to a cardiovascular surgeon for color Doppler. And this is a investigation I have done. This is the Doppler report done, and you can see there is a mild atherosclerotic changes. Mild atherosclerotic changes in the arteries of left leg. So this is the not disease of only small toe. This is the disease of whole leg and whole the arterial system of that leg. That is a process of atherosclerosis. Most important, you can see the background, history of heart diseases in the family, patient taking antihypertensive since many years, and there is a process of atherosclerosis. And that atherosclerosis give rise to a complication, that is a gangrene. You can see. So here the scope for a Boger's approach. You can see the totality symptom Boger's approach. I have learned Boger's approach during my peripheral visit to a village area where there is a less data available and you have to focus on the characteristic, you have to focus on a location, pathology and whatever important characteristic data. Less data but important data. This is the scope for Boger's approach. So I took the totality as per this approach, Boger's approach. In Boger's approach, you will find the first preference given to the location, blood vessel, capillaries. That is the left side is taken important. The process of pathology, that is the atherosclerosis and necrosis. That is the modalities and the sensation. Sensation will come to the last. This is the repertorization done as per totality, and you will see the different remedy come and all the remedy, prominent remedy of necrosis, gangrene are coming in front. First remedy is the arsenic. Second, lachesis. Lachesis also good remedy for gangrene. Sickle core, Protella forager, plumbum, Merksol. Then anthracinum is very good remedy for gangrene. You can see. Also, asafoetida carbo is also present in the rubric gangrene. So out of that, I go for the as per totality and the symptom cover and the first remedy, that is the arsenic album. This is the difference. Three remedy came in my mind. The first remedy arsenic, second remedy sickle core, third remedy is lachesis. So this remedy covering most of the point arsenic. First is the pathology, second is the sensation, that is the burning sensation. Fourth point is the mind, anxiety, fear, that is the part of the anguish state, restlessness, despair for recovery, all covered by the arsenic. Aggravation, cold modality also covered by the arsenic. In sickle core, we will see the aggravation warmth and ameliorate cold. But in patient, there is a aggravation cold and ameliorate by warmth. That is the difference point. We have to check all sector. That is the location, pathology, then the mind, associate mind with the pathology, the thermal and the modality. Entire area we cover. And this is the state after arsenic. In first picture, we gave arsenic, and the last second picture, there is a, you can see the change, the difference between two picture, and after that, calcarea carb was given as a constitutional liquid. We started with the arsenic, and finally, when there is a situation under control, patient out of risk, there is no need of surgical procedure, then we end up case with the single dose of calcarea carb as a constitution. This is the last picture in second image. You can see this picture sent from him from village. You can see the background, and the first picture is taken in my clinic. So this is the difference. And after say this last picture, I said there is no need to come to my clinic. We can stop medicine. So this is the third case. You can see this boy. This is a boy, 2.5-year boy, and the disease is, you can see a swelling on left side frontotemporal area, The location is artery capillary. You can see this picture. This is the case of hemangioma. This is the background. Patient come to my clinic, referred by my old patient. He was the engineer, strong belief in homeopathy. Patient said, I took homeopathy. He is from Madhya Pradesh, MP, and he said, from my native place, I took only homeopathy since my childhood. I am taking only homeopathy. And I was searching a homeopath in city. So my friend suggested me your clinic. And he, before come to homeopathy, he consulted baby to a hospital. That surgeon advised laser procedure, and the approximate charges 25,000 was suggested that time. Patient was rich background. He ready to afford that amount, ready to pay, but he don't want surgery. He said money is not issue, sir, but I don't want to hurt my child. In previous case, there was a financial problem. Here, there is a no financial problem. But word of the patient, I don't want to hurt my child with the surgical procedure. So again, this is the scope for a homeopath. When patient's parents are not ready. So we started a treatment. Again, bogus approach. Why? What I learned in my practice, the bogus approach is repeatedly coming or useful in the cases. Why? So, as per organon of medicine, as per Dr. Samuel Hahnemann, the concept of one-sided diseases. The many surgical cases and the concept of one-sided disease is fitting in bogus approach. Pathological general is highest important as per bogus approach. Pediatric case where the child is not ready to speak too much. In adult case, we took case for longer duration, 1 hour or more time, and we get all data. But pediatric case, we get little data. Though it is called as paucity of symptom as per bogus approach. And when there is a surgery advice, when there is a pathology, when there is a change in tissue, location, affinity. See, most important part is our practice. Uh, it's very easy to manage the cases which are functional or cases which, in case where there is a no change in your anatomy or your system. That part is very easy. For example, whenever there is a headache with all investigation normal, we can manage very easily with the medicine. But when there is a change in the our body, change in the anatomy, change in the tissue, and the pathology changes, then this is the challenge. But good part of this challenge, I will say, we can show to the patient, to the world, hmm, there is a change. Most important, we can show the reports, we can show the sonography report, x-ray report, we can see the color Doppler report, we can show the pictures before after. That is a good part of pathological cases. So you all, my suggestion, you can start accepting the case, but you have to take care of the patient, whether there is a life situation, life threatening situation or not. You have to take support of other pathy also in that situation. So this is the totality as per Boger's approach. And in this case, the first remedy came, that is the merge solve. This is the repetization done that time, and I gave the merge solve as a remedy on the basis of Boger's approach, that is the location, pathology, destruction, necrosis, the miasm. It is a gradually growing tumor. The redness turn into black, irritable, extreme irritability, is not ready to touch for examination purpose. And see the follow-up. This is the follow-up. First consultation, 3 doses given, daily 1 dosage on 2nd August 2017. And you will see after 3 doses, I gave 1 dose after almost 22 days, 28 days, 1 dose. And after 3 months, 9, 10, 11, the 5th dose was given. And patient came to me for a 1.5 year. And in this case, I learned most important point is the patience. You have to remain in a state of patience. You have to not do hurry when there is a good result. As per second prescription, as per organon, Dr. Samuel Hahnemann, he said that when there is an action, then wait and watch. And in this case, I gave only 5 doses of Mersol in a 1.5 year. 1.5 year में सिर्फ मैंने 5 डोसेज दिए मर्सॉल के. नो frequent for very frequent repetition, because the remedy is acting well and there is a result in the photographs. We will see next. So no frequent repetition. This is my learning from this case. You can manage the case with minimum doses as per concept of homeopathy. So this is the law of minimum. Only 5 doses of 30 potency in a complete journey of 1.5 year. And this is the picture of hemangioma. You can see the change. And you can see this is the last photograph. This is a small. At one side there is a first picture and the last picture. And this is the time I have stopped the medicine. This is the first picture and last picture. 2nd August 2017 and 10 December 2018. This is the time patients stopped coming to me. The treatment was closed. So this is the end of this session of all cases I have share with you. Final conclusion, I have to give a take-home message to all of you. That is acceptance, which cases to be accepted under the scope of homeopathy and your skill, and reject the cases which are life-threatening or out of your scope, out of your skill. You can refer to your teacher or an expert homeopath around you who manage such cases, and gradually you learn from them. And in future, you can manage such a cases. But you start as a beginning to manage such a pathological cases. Understanding the case is very important. Acute, subacute, phase remedy, and chronic. You have to pick up the exact phase, what phase is going in the case, and you have to give remedy accordingly. Importance of understand the susceptibility. In every case, you have to understand the pace of the remedy, fast, slow. In one case, we have seen the fast pace. We give tuberculum. One case there is a slow pace, so we give infrequent doses, less doses. You have to understand the pathology, what PQRS coming in that pathology, and over the vitality of the patient. Which case is very weak, underweight, then we have to take care of that patient first. Miasmatic understanding, fundamental miasm. In case of that toe gangrene, we considered the fundamental miasm, the family history, and what dominant miasm, that is a psychosis miasm, and teamwork. Finally, you have to learn a teamwork. If this is not a work of a single person, you have to take the suggestion from, you have to talk with the surgeon, you have to refer patient to a surgeon, ask him what is the scope of your side, what is the scope at our side. You have to talk with the radiologist, you have to discuss all report with him. And supervisor means your senior homeopath, your senior teacher. You take guidance from them. The most important is Guru Shishya Parampara. As per our concept of Palghar, MLT, MHI, Dr. ML Dhawde sir, they taught us the concept of Guru Shishya Parampara, that we are following till this day. We are constant in touch with our senior teachers for the management of the cases. And last part is the keeping in mind the possible complication. Means if there is a result in one case, it doesn't mean you will get result in the next few cases. Some cases, these are all representative cases in my practice. I have also failed in few cases. Few cases got surgery, few cases got admitted. Even the last stage cancer cases, they got expired before coming to me, or during the treatment of my treatment and the treatment of oncologist, or chemotherapy, radiotherapy. So we have to keep in the mind that there is a possibility of complication. You have to understand the complication, refer patient immediately in that phase. Don't be obstinate to handle, I will handle this case fully. You have to consider the complication part. And the this is the take home message to all of you. This is my experience of my practice of last 16 to 17 years, and I will hand over mic to a organizer team.
Thank you, sir. Thank you so much for the extensive session. It was a quite warm section, sir, with all the case in detail explanation. We would look forward to many more sessions, sir, from you. And we thank you, sir, for your extensive session. Thank you, all the participants, for your active participations. If there are any doubts, you can comment in the comment box so that sir will be answering it. Yeah. I hope they were clear with all the cases, sir. So we will end up and wrap the session, sir. So thank you all. Thank you, sir, so much for the
Okay.
extensive session. Thank you all the participants, and we will look forward for many more, sir. Thank you, sir. Thank you all the
Thank you.
participants.
Thank you. Thank you.